this is a multi-stage technique. In order to effectively stretch the adductors, we've got to start by stabilizing the hand here. So index and middle finger, so second and third digit, I'm going to come across here to the metacarpal, and I'm going to stabilize with one hand. Okay. I'm going to take my other hand, and I'm going to move the first metacarpal. Everybody point to where your let's remember where our metacarpals are. Okay. I want you all to point to your first metacarpal for me. Good. Okay. Everybody tell me where your first MCP, metacarpal phalangeal joint is. Which one of the thumb? Where is it? Which one is it? Which joint? Okay. Right here, right? If there is one mistake that we see common on lab practical, it is confusing the CMC and the MCP. Okay. So let's just get another repetition. This is MCP, this is CMC. Okay? So again here, I'm going to take Ebony's hand, I'm going to stabilize the second and the third metacarpal with one hand. I'm going to take her first metacarpal, and I may bunch skin a little bit, and I'm going to abduct, okay? The T-shirt minus, that's away from the palm. And I'm going to hold this position as step one, okay? I think it's a stage one. Then I'm going to move the first MCP into flexion. So maintaining abduction of the first metacarpal, and then I'm going to take my hand here and I'm going to push. You okay with the squeeze? Mm-hmm. Okay. That first MCP into flexion to stretch the adductor pulses. Okay. All right. I'll tell you what. Why don't you spin around? Let's show what it looks like on the other. That's the same on the other side, but let's compare. So on this side, again, I'm going to stabilize the second and the third metacarpal with one hand. I'm going to abduct the first metacarpal away, maintain that stretch, and move into MCP flexion. Okay. Then I can just hold and do a static stretch. So that is adductor pulses. Now, it doesn't talk about this, but I might, in somebody who's really tight there, I might do a little bit of soft tissue, just using other techniques that you have. Maybe I come in here and I use some inhibitive pressure. You know, I may come in here and see if I feel any trigger points, little taut bands that are irritable. So I may come in here first, do some stretching, okay, and then, or some soft tissue release, then come in and follow that up with a stretch. What might a supporting intervention be? Or let's even backtrack a little bit, okay? What joint might you address? So what would it, if it was tight, what would it restrict? Abduction of the, okay, of the what? Thumb, probably where? Probably CMC. Okay, so what joint might we think could also have issues that we might want to check that might also CMC what? CMC what is responsible for CMC abduction, abduction? Oh, it's taking us back. CMC abduction. What would we need to do? Away from the palm, dorsal glide, right? So that you might, so in a practical scenario, which this is very, I think, very highly likely that it could be on a practical, right? So there is a joint that you could assess and treat as indicated. Okay, what would a supporting intervention be then?
Could you do a band around the thumb and have it abduct?
Okay.
It's like this way.
Okay.
Abduct against resistance.
Okay, so tell me your rationale and why you would choose to do that motion.
Because it strengthens the adductor pollices.
Okay, in what manner?
Concentrically.
Concentrically. Okay, so we know that the adductor. So while you could be right, and you'd have to connect that, what did Dr. Carter say he wants our first line of thought to be?
Eccentric, right?
Okay, so how might you work it eccentrically?
I could have the band the opposite way and then have it control the abduction.
There you go. Okay, so that's a good one. Now I'll also show you a self stretch. Okay, somebody who's tight in this. Let me just show you this because I think it's a good tool to have in your toolbox. Okay, is a self-stretch, right? It's hard to do that to yourself. You know, a lot of things we can do with self-stretch. This is a little hard for me to stabilize here and get here and do this effectively. But I can take my hand and I can put it around, you have the camera? I can put it around here, find the right width or diameter of something that gets separation between my first and my second metacarpal, and then apply some flexion. That's probably a little bit much for me. Let me go a little smaller. I can get here and then stretch like so. So that's also a self-stretch that you can, you know, just something to have in your toolbox that you can help. Could you use a rubber band? For what purpose? For strengthening purposes? Absolutely. A rubber band's a great tool that you could have. You just have to find the right resistance. So you're probably getting some resisted strengthening, but when you stretch a muscle and strengthen when you're elongating it, what do we call that? Respect. All right, so that's adductor polysis. So we want our patient to be comfortable. So I'm doing prone techniques. If I'm doing prone techniques, I'm typically going to put a pillow under their waist. Okay, I may put a pillowcase around that face or whatever. I want them to feel like they can relax. If they're not relaxed there, I may even get another pillow. And put it under their feet. Some of your patients are going to be really tall and their toes are going to hang off and they're going to be comfortable. If not, if I feel like she's engaging her muscles to try to keep her leg from rolling out, then I'm going to come in here with another pillow. This one's nice and warm off the hot pack thing. And put her there. Now she can totally let go of her. I want her to let go of her legs, and I want her to be able to rest down where she can also let go of some of this tension through her lower back. Okay? So whatever we need to do to make that happen. If she's good there, great. If not, I'm going to adjust the face hole. I may have to use some more pillows, but I'm going to get her in a position where I can get her relaxed. Okay, for the sacral release technique, there's 2 or 3 slides here showing different usage of the hands to accomplish the same thing. All right. So sacrum, I want you to envision it here. Is it wider at the top or the bottom? Top, right? So up here, the top part of the sacrum, what is it coming together with? Okay. The innominate, I heard. Good. So you can see, and I think this slide describes it, but there's the innominate, okay, or the ilium comes, and it's about half of the sacrum is the SI joint, where it's coming together and joining. But this bottom half right here of the sacrum has a lot of muscle attachment coming in, okay? And so this is where we're gonna perform a sacral release. All right. So this first slide here shows a technique where we're gonna do a general stroking. So here's what this looks like. I'm gonna envision in my mind her sacrum, and I can feel right here. This is her SI joint. I can feel that groove. Okay, a slight groove here where the innominate or the ilium is coming together with the sacrum, and I can walk down to where I feel like that ilium disappears. Now I know I'm on the side of the sacrum where there's a lot of muscle attachment. Here's what my hand placement looks like. My thumbs are together on one side of the sacrum, and if you see, I've crossed my index fingers, and now my middle fingers have come together on the other side. Okay? Y'all see that? All right? Now I can get here where I can get on the sacrum and I can just stroke along it, and I can go on both sides of the sacrum. The slide describes it going from distal to proximal. Okay, honestly, I do both. I go distal to proximal, and then I work my way down. Okay, so it's almost like I'm squeezing along, so if you can imagine the sacrum too, I'm doing this. All along where those muscles and tissues are attaching to the side of the sacrum. Yes, David?
So I noticed Dr. Carter has a towel. So as a male therapist, and if I had a woman's patient, you would advise me to have a towel
would advise you to use your best clinical judgment, okay, on this. This is one that sometimes on my patients, I will do directly skin on skin. And when I do that, I will use a towel, I'll get their consent, and I will drape as close as best as I can. This is a technique, especially when you're talking male to female, that you're gonna wanna educate your patient. Hey, I'm seeing a lot of restriction right here. I feel like you're bound down around the sacrum. I would show them on the model. There are a lot of techniques here. Dr. Carter says, which I think is a great idea, he gets his books out. He shows them, hey, this is a real legit technique. This is what I'd like to do. Are you okay with it? Okay, get their consent. And then most of my patients, I do it through the clothing though. Okay, this is one. You're probably more effective skin on skin, but you use your judgment there. You can still accomplish something through the tissue. With the towel there, if you're putting a towel directly over this, you may have a harder time. Like the more layers you have, the less effective you're gonna be. So you're just gonna have to use your clinical judgment. If you're apprehensive about it at all, I wouldn't do it, okay? Find another way to accomplish what you need to accomplish. But communication, I think, is key, and getting their consent, but educating them about why you're doing this technique, what exactly you're gonna be doing, so they're not totally surprised by it. But that's a good point, Tavian. I'm glad you brought it up, okay? Yes?
So if you're not comfortable, could you potentially use like a scraping tool instead to maybe get the
You could. Of course, if you're using a scraping tool, you're almost definitely gonna have to be skin on skin. You're not gonna be able to accomplish that. So then you're definitely getting into where you're exposing, so what you may feel more or less comfortable with. But again, it's your clinical judgment, okay? Listen to that gut intuition. There's gonna be patients where you're just like something, you just don't have a piece about it, don't do it, okay? Don't do it. Listen to that intuition. So this is one technique. So I can scrub down proximal to distal, distal to proximal, and so that's how it looks bilaterally, okay? Honestly, a lot of times I will transition and do this unilaterally, and I will keep the same handhold, and I will work. I feel like I'm more effective here doing this unilaterally. I'll do it on one side, and then I'll go to the other side. And so I'm going like this, all along where the muscles are inserting right at the edge of the sacrum. And I'll go all the way down to the ILA, and back up. And then I would go to the other side, and I would do the other, okay? Again, these are tools in your toolbox. My hands aren't as wide as Dr. Carter's, so I feel like I do a little bit better unilaterally. Can I do it bilaterally on some of my patients? Yes. On the other patients, I can't even get my hand in a position to feel like I can get around their sacrum, okay? So what muscles are attaching here on this lateral rim of the sacrum? Right here. What muscles will be attaching here? Okay, ooh, external rotators. Okay, so our rotators, even some of our internal rotators are coming and attaching to that lateral side, okay, or that just anterior, just posterior to that sacrum, right? So our rotators. So if we have somebody who's lacking rotation, or we feel like there's some tightness in those muscles, this is a technique we can do to try to release. So a lot of times I will do this technique in somebody who's got some tight rotators, try to release them, and then I will follow that with a stretch, okay? So maybe I have them doing something to stretch their external rotators, maybe a piriformis stretch or something of that nature, okay? And then we can follow that with some kind of either concentric or eccentric strengthening, depending on what we're gonna do. You guys aren't learning SI modes in this class, so that would probably apply more in spine. We'll have to try to make that connection in spine class. But in regards to the hip, let's say we had somebody who is lacking external rotation, and you chose to use this technique to release some of the rotators. What might you look at from a joint standpoint? That we have done in this class. A glide of what? An anterior femoral glide on the acetabulum, okay? Which is necessary for what motion? External rotation, right? So if I had somebody lacking hip external rotation, I wanted to work on their rotators, okay? Did some anterior glides of the hip joint, femoral acetabular joint, and then would we follow that up with what kind of exercise or supporting intervention? Some clams or some reverse clams or something to work that, you know, on how we want to strengthen eccentrically or concentrically. Okay, all right, good question. Let's tie it all in together. All right, so that's one technique. You got your bilateral sacral release like this. Okay, you got my version where if you can't get around it, you can go unilateral. And then here we have another technique. Still same purpose as far as releasing the lateral side of the sacrum and the rotator muscles that are attaching. Okay, so in this particular technique, Dr. Carter is using the thumb and the thenar eminence of the top hand, meaning the hand closest to the patient's head. Okay, if I'm on this side, that would be this hand. And then taking the palmar surface of my caudal hand, the one closest to their feet, over top of their thumb and thenar eminence, okay? And then giving an oscillatory pressure. So I can come here like so. I like to do it this way, the way I just showed you. But another way that you can do it is you can take, again, top hand, thumb and thenar eminence, put it here at the base, take the palmar side of the other hand, put it here, and I can just do some oscillations along the side. So it says I can do a medial to lateral, okay? Or I can do a cephalocaudal. So I can go cephalocaudal, so from the head toward the feet, oscillatory pressure releasing along that sacrum, or I can go medial to lateral, right? From the midline toward me. And I can come down and release in this way. Another technique, same desired effect. Okay. Now, there's a third technique here, which is, we call this buffing. Okay, buffing's another word for it. But I can take the palm of my hand, and I can just get here like so. And I can just make some circular motions all along. And I like to use my pisiform. Okay, I feel like I got a good knobby pisiform. It's a good to get in here and release the side of the sacrum. If I've been doing a lot with my fingers that day, I will tend to revert to this technique. This gives my fingers a break. If you're doing a lot of manual stuff, that's what it looks like from this side. And I'm just going along that whole lateral border till I get down to the ILA. Buffing. Okay, again, communicate with your patient, show them the pictures of the technique, make sure they give you consent. Any almost always puts me at their PSIS, okay? And once I find their PSIS and I drop in, I know I'm at the base of the sacrum. Then I can walk my way down and I can feel the edge of the sacrum. And once I keep walking down that sacrum and it's bony, bony, firm, 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 and oh, really soft, then I've gotten to where I'm off the ILA. Okay, but that's how I like to locate. So maybe you were saying, how do you know you're on the sacrum? That's how I like to find the sacrum. Okay? Any questions about that? Okay, we're going to move to some piriformis techniques. So this is designed to create friction. This is a friction of piriformis insertion. So where does the piriformis insert? Greater choke. Okay, so we got to be able to find the greater trochanter. You know, good with finding the greater trochanter? So if the piriformis is inserting at the greater trochanter, you can imagine this patient is laying prone. This is what we're doing with this technique. I'm finding the greater trochanter, coming just medial to it. I'm going to put my thumb right here, okay? And then I'm going to bend that patient's knee to 90 degrees. And I'm going to internally and externally rotate while I'm holding pressure on their tendon. It's just going to cause, it's like it's a friction, but I'm creating the friction. I'm holding the thumb still and creating the friction by internally and externally rotating the femur via the knee, okay, or via the tibia. All right? So this is how this looks. Again, it's just a habit. I come in here, iliac crest, drop down, here's SI, I can work out to my side. Oh, here's the firm bone here, this is greater troch, right? So now I can start here just medial to that greater trochanter. Okay, and I can put my thumb like so. You okay? Okay, this can, in your patient who's having issues, it may be a tender area. So you're gonna ease in, get a tolerable pressure, and then I'm just gonna internally and externally rotate. What special test did we do where we were feeling the greater trochanter? Craig's, right? So this is not Craig's, but it's similar from the standpoint that we're internally and externally rotating, except for this technique, I'm putting pressure on the piriformis tendon, which is just medial to the greater trochanter, versus Craig's where I'm feeling trochanter, okay? That's how that looks. So on the other side, okay? Here's greater trochanter. I come just medial, get my thumb here. Now, I can only hold this position so long. Y'all know I've got some hypermobility, some laxity in my joints. I can't do this all day. Okay? So sometimes I will modify and I will go with a knuckle. And I'll put my hand like this to protect my finger. And I'll come in here. I'll try to use the medius part of my middle phalanx that I can, but still apply pressure. And I can accomplish the same thing. It's probably not as comfortable, is it? Okay. And so that is the friction of the piriformis insertion. All right. Any questions about that? So treating some more of this muscle, we can do a piriformis release. How many of you all have learned a piriformis release somewhere or seen it in the clinic? Okay. All right. A handful of you. A lot of piriformis release that goes on. So there are 4 options here for a piriformis release. So we're going to start with the first one. We're going to use the palm of our hand in the area of the mid-buttock, midway between the sacrum and the greater trochanter. Okay, so again, I'm going to come in, I'm going to localize the piriformis. I'm going to come here, iliac crest, here. Now I know I'm on the sacrum. If I come across here, here's greater trochanter. I know that here's the sacrum. So midway between, so we know that the piriformis is running between there, right? So I can come to the mid part of the belly, right in between here. Now, is the piriformis a superficial muscle or a deep muscle? Deep. So I'm going to feel some other muscle before I get to the piriformis, right? What muscles am I going to feel over top? Glutes, right? So I'm going to have to get enough pressure, so I'm going to get the palm of my hand, okay, and I can come down again. I feel kind of weak. Dr. Carter's very strong. He's here. You can either get one hand here and stabilize. I either have to do this or I have to do this, okay, to be able to feel like I can get the pressure that I need to sink through gently the glutes to get to where I'm going to find the piriformis. So I've got a couple options, right? I can get here. I would probably put her down just a little bit so I can use my body weight sinking through the glutes until I feel, and this is just, it's a lot of practice. And I would encourage you to just do that. Feel superficial muscle, getting deeper, I'm getting deeper, okay. I feel like I'm probably into the next muscle there. So this should be about where piriformis is. And I can just hold some inhibitor pressure. That's how it looks that way. I can get here like so, and do it like this, okay? So that's the palm of the hand technique, just holding pressure. If they tolerate inhibitive pressure well, then I could start to do some longitudinal strokes. What direction would that be for the piriformis? What way do those fibers run? Good use of terminology, medial lateral, right? So they are running this way. So if I wanted to do longitudinal stroking, that would be this direction. If I were going to do transverse stroking, if they tolerated longitudinal and I wanted to do some transverse stroking, I could go superior, inferior, right? Or cephalocaudal, caudalocephalic, all right? So that is the palm technique. How many seen people walk in the clinic and see somebody with an elbow in somebody's behind, right? So I can get here, and sometimes I will get here, and sometimes I will even externally and internally rotate just to see if I can feel some of those rotators a little bit more. Feel like I've located piriformis, and I'm going to sink in here. Now, again, people who have piriformis issues, they're tender. So you don't want to go in there wild and crazy and just like, not gonna feel good. And when we're treating a muscle that's taut and tense, you're feeling for tension, right? Every muscle has got some resting tone. So my biceps, if I feel it here, go ahead and feel your bicep like this. Even with my arm hanging and it's fairly relaxed, I still feel some tone in it. Can you feel that? Okay, if I make a contraction, do you feel the difference in the tone? Okay, that's kind of what we're feeling for here. And some people who are feeling that resting state, does it feel like there's increased tone, decreased tone? Okay, even with Dominique, I feel like she may have a little bit of increased tone on this side compared to this side. Can you feel that? Is it sore? Like she's got more resting tone right here. She's actually is a little tighter on this side, okay? It's more taut, okay? So I found a spot right here that I want to treat, okay? So again, I can do that palm. I can get here with the elbow. The elbow is kind of when I don't use the elbow very often because I can't sense as well with my elbow. I can feel a lot better how she's responding to me with my hands, my palm, than I can with my elbow. But if this person is just, man, they are just super taut, they are really big, and they're tolerating when I'm doing pretty well, but they need it, then I might transition to using my elbow. Now, what nerve runs through here that can be problematic? Sciatic nerve, right? So if I'm doing this and that person is getting like zingers down their leg, what might I want to do?
Release some of the pressure.
Release some of the pressure, maybe move. Maybe I need to shift a little bit. Maybe I need to come just a little bit different, okay? Now, you can have trigger points that you can stimulate and you can also get referral some symptoms down there, okay? But if we're putting pressure on a nerve and it's causing radicular symptoms, we do want to back off. So that's how the elbow technique looks, okay? The other side, again, greater trochanter, sacrum, midpoint of the muscle belly. Okay. And I can hold inhibitive pressure. Again, then I could progress to doing a longitudinal stroke and or transverse stroking. All right, so that's the elbow. Then we've got fist. So the fist, obviously going to make a fist, same thing, greater trochanter, sacrum, midway between. I know that this is about where the piriformis is. I can get here. Okay. Sink through, inhibitive pressure. Then I can do some stroking, longitudinal, transverse, and then the other one is a two-knuckle approach. Okay, so you can take the couple knuckles, one from each hand, come in here, put them next to each other. They become like buddies, buddy knuckles. And now I can get in here a little bit more precisely. Okay, my fist is big. If I have a big patient, a large patient who has a large piriformis, I might opt for the fist technique. If I have a very small patient who has a very small in diameter, okay, piriformis, I might go one knuckle or two knuckles to come in here and start with inhibitive pressure as tolerated. And then, so when I treat with inhibitive pressure, am I just hanging out here as long as I feel like hanging out, or what am I feeling for? Release, right? What does that feel like? Anybody describe what they think that feels like? Yeah, yeah. So you feel like there's some of that tension that you initially felt starts to relax or release a little bit. Okay? There's not quite as much tension against your pressure as there was to begin with. And so you just hold that as long as they tolerate it, or as long as you feel like that release is occurring. When it feels like that plateaus, then I'm going to back off. Okay? And then reassess whatever it was to begin with that I felt to be a problem. Alright, so we're talking piriformis now. What do we know about piriformis? What are its muscle actions? Okay. Yes and no, right? It's a tricky one.
Oh no.
It is an external rotator in a certain position. Anybody remember those? When the hip is flexed, okay? So make sure you understand that. Make sure you know At what range of hip flexion is it an external rotator? At what range is it an internal rotator? And make sure that your supporting intervention is appropriate, okay? So you want to make sure that if you are doing this to because you felt like internal rotation was limited and you felt like piriformis may be a culprit, then make sure when you're doing your supporting intervention that you're engaging that piriformis in the range where it is an external rotator, okay? All right, so there's one more piriformis technique. This one is sideline. So I'm gonna get patient sideline, okay? Get my patient comfortable, get them on their side, pillow here. Y'all know I like pillows. I'm probably gonna put a pillow under the knee, okay? And I'm actually gonna use this one to help me as well. So for this particular technique, I'm gonna bring definitely that top leg up until she's about in 90 degrees of hip flexion, okay? Bring you up a little bit. This is another one. You wanna have good communication with your patient, okay? Let them know what you're seeing, what you feel like is contributing, the technique that you feel like it would be beneficial to them, why it's beneficial to them, show them a picture, you know, whatever you need to do to make sure that they understand and you all are on the same page and that you've got their consent. So again, we know, so here's greater trochanter. Now I'm going to come across. I feel that firmness there. There's the sacrum. I know piriformis is running between here and here. So for this technique, I'm actually going to use the top knee to give me a little bit of help while I'm releasing this. So I'm going to take her knee and I'm going to put it right against the front of my hip. Okay, I'm going to stand in a little bit of a diagonal lunge stance so that I can be stable. But I'm going to reach across here and I'm going to come to the edge of her sacrum and I'm going to strum medial to lateral. So I'm going to follow those fibers longitudinally across to where they insert at the greater trochanter. Okay. Now, if I just do this without it, I'm just going to pull her whole leg over. But I'm going to give a little bit of counter pressure here so that I can have a more effective stroke along her muscle fibers. Okay. So I like to use this technique. Okay. Again, it just gives me more stability to my fingers. Yeah, Dr. Carter's doing the same thing. Okay. That's just it's a good technique. It helps me to be more stable in my fingers as I'm doing it. So I'm doing most of the work with these two fingers, maybe a little bit with this, so primarily with the third digits next to each other, maybe a little bit with the fourth digit, and I'm coming across. Okay, so I'm just stroking across with counter pressure through the femur. For the greater trochanter rocking, this technique is utilized when internal rotation restrictions of the hip are present and we're trying to release restrictions in the hamstring. But I want to do this one first because this is one where you can see a significant increase in the straight leg raise. So I said, let's do this first. Let's see if we see any change. And then, because the next technique also deals with hamstrings, so let's do this one first. All right? Because it makes a big deal about it on the slide. Now your pocket there for a second. Okay, so I'm going to bring Taylor up. I'm going to start. I'm going to show you how this looks standing and how it looks seated. But first of all, let's see what her straight leg raise looks like. Okay, so we're going to do a passive. I'm going to do a passive one first. Let's just see. Okay, so everybody visually see it. Okay. You actively lift it for me. Okay, back down. All right, so then the technique, this is what it's going to look like. Okay, the same side. So all right, so if we can envision our patient here, I'm going to get around here, around the greater trochanter, with my fingers like this, okay? And I'm going to perform a PA motion, okay? Like so, on the back of the trochanter. And so you can envision if I've got this bone like this and I'm far enough lateral performing that, do you see how that's going to encourage internal rotation of the femur? You see that? So I'm getting right under the greater trochanter on the lateral side of the femur, and I'm going PA, right? And as I do that, it's encouraging that bone to move into internal rotation. So my forearm is gonna be supported on the table. I'm gonna get my hand like so, so my cephalic hand, the one closer to her head, is gonna be right here. I'm gonna reach across. Here's trochanter. I'm gonna come just underneath it, and I'm gonna get my hand like this. And this is the motion that I'm creating, okay? So you can just relax. She's just going along for the ride. You don't want her to help you, you don't want her to resist you, you just want her to be relaxed, okay? Is that uncomfortable? Sure? All right. Okay, so I'm just gonna get that going like so. So again, this is what I'm doing. You see how her toes are wanting to start to turn in? Now, I can give a little bit of help with that by taking my other hand and getting here on her distal femur and just encouraging. Still, most of the motion is happening with my cephalic hand under the trochanter, but I'm just encouraging a little bit more rotation, like so. So by internally rotating her femur, I'm inhibiting the external rotators, okay? And so, and therefore, and all those muscles that are attaching right here. So this is the greater trochanter rocking, okay? So I'll spend, a minute or so working on this, and I do use this in the clinic a fair amount. It's a good technique. And maybe, and we talked about hip replacements today, so your patient who is not allowed to go into internal rotation because of hip precautions, this might be a technique you can use on them to just get them to neutral. Maybe you're not forcing them past neutral, but if they're here, okay, maybe you do this to get them toward neutral to release that muscle, because you can't just take them up here and be doing some stretching, okay? All right, so let's see. Let's check the straight leg raise. I don't know, does it feel any different to you?
Super tight.
Okay, all right, you do it actively. It's a little bit better. I think it's a little bit better, okay? It shows it's standing, but sometimes I like to do it seated. I feel like I can get the angle of my arm better, and maybe my forearm. I want at least my wrist stabilized. So in fact, I'm gonna let you scoot over just a little bit. Then I can at least get my wrist supported, okay? So again, I'm gonna come here, find the trochanter, come just underneath it, and it's this motion. Okay? Wow, we forgot to look at your leg. Look at your leg. All right. Okay? Tighter over here. Okay? All right. Why don't you lift it? Let's look at your active. A little better actively, but okay. All right. Trochanter, coming around, cupping it. Okay, get the rock going. Okay, give a little bit of help. See if we can release these tissues. You okay with that? Okay, all right. Let's check. Definitely better. Okay. All right. You go ahead and you do an active. Okay. So.
It was half a ceiling thing.
So you gauge it on. Okay. So that's the greater trochanter rocking. All right. And then we'll come back. Go ahead and flip over on your belly. Pillow under your waist, please. We're gonna do another technique that this is gonna be at the ischial tuberosity. This is where hamstrings insert. So when I put this pillow here, what effect is that gonna have on the hamstrings? If I put a pillow right here. Flatten. Yes. Okay. So what is the muscle action of a hamstring? Extension. Okay. Knee flexion, hip extension. Good. So if I put the knee into more flexion, it's gonna slack. Okay? But we want to keep that in our mind because we're thinking about where we're headed from here, right? So for this technique, so ischials, right? People will call them your sits bones. You can all feel them on yourself. You reach down, if you're sitting right now, that bone that you feel yourself sitting on, ischial tuberosity, okay? It's pretty prominent, right? But we know that that's where our hamstrings are inserting. So here's trochanter. I know if I come right here, there are her ischial tuberosities, okay? So this is also typically right at the gluteal fold. So when you see your patient's gluteal fold, and I can envision in my mind, her sacrum is here, okay? It's fairly in line with, if you can see here on Charlie. It's almost directly inferior from the PSIS. So if you know where the PSIS is, you come down here, gluteal fold, that should be where you're gonna find ischial tuberosity. Okay? I'll stay on this side here. So if I wanna come right in here, I can find, there's the firm ischial tuberosity. I know the hamstrings are coming from here, so I'm gonna come just caudal or inferior or distal to the ischial tuberosity, and just similar to what we did up here at the sacrum when I used one hand, I can do that here. Now what I'm gonna do is I'm just gonna put, I'm gonna put my fingertips right in here, find the ish tube, come just down to where those hands, and I can feel that tendon right there. And I can just strum across it. So I can do a transverse friction, okay, across that. Are you okay with that, Tisha? Okay, I can also do a little bit of longitudinal stroking and release, similar to what I did at the lateral border of the sacrum. How did your slide describe it though? Does it say medial and lateral? Yeah. Okay. So on the other side. Come here, ish tube. Come just slightly caudal to where I feel those tendons, and I think you'll be able to feel the tendon here. It's got a different feel to it than muscle does. Okay. What else inserts at the ischial tuberosity? What big ligament? Sacrotuberous. Yes, sacrotuberous ligament. Okay. Good job, Tammy. All right. So sacrotuberous ligament, and some people will say that the hamstring tendon actually may have, there may be some, what I'm looking for, common union, okay, that there may be, those fibers may intertwine a bit, okay? So you probably get some sacrotuberous ligament release here as well. All right, when we stretch a muscle, what do? We increase sarcomeres, right? We stretch a muscle, so we've got these fascial sheaths, and sometimes this gets tight. And so this technique is a bending motion that we're going to use to facilitate stretching of the surrounding fascial sheath. We tend to see more restrictions in the vastus lateralis. So for this particular technique, we're going to start by going from a lateral to medial direction. Now, you could also stand on the opposite side of the person and go medial to lateral. You could, if you felt like there was more restriction for some reason on the inside of their thigh, their quad, you could do it the other way, but we're going to learn the lateral techniques because that's where most restriction typically is, okay? So, do I have, and this one really needs to be skin on skin to be effective. So if this is one where I really encourage you to be standing, so usually when I have a patient, I ask the patient to like that, then I will tuck it in. Okay, I usually use a towel, but in the absence of a towel, I'm gonna use this. So I'm gonna get her right here, and then, right, if I step away from my patient to do something or grab a tool or whatever, I just boom, right? But they're still ready when I come back and I'm ready to continue with what I'm doing. Back here. All right, so for this technique, you want to be standing, and you're going to get the table up as high as you can so that you can get in an athletic stance here and be able to have good body mechanics as you're doing this technique, right? So quad, we know quad is here. What band is coming through here? IT band, right? So we've got quads inserting above. What's inserting below? Hamstrings, right? So I'm going to use that IT band as a reference point. I come here, I find my IT band. I know the quads are above that. What I'm going to do for this technique is I'm going to take one hand and I'm going to stabilize, okay? And this picture is not the best picture. The hand appears to be below the knee. It really needs to be above the knee, okay? So the bottom hand's going to stabilize just above the knee, and it says that in the slide, proximal knee joint, but I don't want you to be confused by the picture. But the top hand is going to do the technique. So I'm going to get down here like this. I'm going to get in a lunge position. And I go like this, all right? And I've got the IT band here. I'm coming just above it. I'm going to stabilize with one hand here, and then I'm going to take this other hand and spank it her up here. That's it. Okay. So I'm going to get here. stabilize. I'm gonna take my other hand and I'm gonna take that quad and essentially try to bring it up and over the femur and push it that way. So it's almost like I'm bending the quad in my hands, okay? It's not a pleasant technique. This is one where you don't wanna just hang out there, okay? Your patient is not gonna like it. This is where you're one where you're gonna get here, you're gonna get up, get in, get out, okay? Get in, get out. So I'm here stabilizing, I'm grabbing the quad. I got you nervous now. All right, I'm gonna pick that quad up and I'm gonna bend it, okay? I'm gonna pick that quad up and I'm gonna bend it. I'm gonna pick that quad up and I'm gonna bend it, okay? Pick that quad up, and I can probably only go to about here. Pick the quad up, bend it. Sorry. All right. And I feel her starting to resist, so I'm gonna back off for a second, okay? It's all right. It's an uncomfortable technique, okay? Courtesy rub down, right? All right, so the courtesy rub down, what else am I doing? I'm stimulating some receptors, right? They're probably gonna have some neurophysiological effects and help her to relax a little bit better, okay? You see me do that a lot, that's why. Leave them on a good impression, right, too? You're done with the technique? All right, so I'm here, up, and bend. So I don't wanna take this quad and jam it into the femur. I want to take the quad, I wanna lift it up as best I can, and I'm having and then I lift it up, sink in, and bend, okay? Lift it up over the femur, bend against the gentle counter pressure of the bottom hand, bend, okay? All right, so let's see what that looks like on the other side. So now, again, bottom hand, stabilizing, I'm gonna find that band. So here's my reference point. I know the quad is just above that, so I can come here distally, up, lift up, and bend, okay? Lift up, over, and bend. Lift up, over, and bend. So just imagine against the counter pressure that I'm just taking that muscle and doing this to try to stretch that fascial sheath and lining over it, okay? Any questions about that technique? Quad. What is the muscle action of the quads? Okay, I heard superior patellar glide. Okay, what did you say? Anterior glide of what? Good answer, okay? Good answer. So those are some glides you might check. What about supporting intervention? Short arc, okay. Okay, what would be your rationale? So you could get some eccentric even doing the short arc, right? Because as you're lowering down, you're strengthening eccentrically. Okay. You just have to be able to connect the dots. You guys are doing well. You're getting the thought process. Just think that way. All of this, okay? All right. So that technique too. This is one where you don't want to have some lubricant on the leg, okay? If they've got a lot of lotion on, you might even have to wipe off the lotion, or you're just going to slide all over the place. This is not one that you want to use deep prep, free up, anything like that. This next technique, however, we do want free up or deep prep. We're going to see if we can get to your trochanter, an exposed trochanter. That's pretty high, but that's the goal, okay? All right, so here's Letitia's greater trochanter. So trochanter, IT band is coming down here. So again, you guys told me a minute ago, quads are anterior to that, hamstrings are posterior to that. So this is a release technique for the quads and the hamstrings along the IT band, okay? So for this particular technique, and I think there's 2 slides here, and they're pretty well the same technique, but here's what we're gonna do. I don't like to stick my hand back in once I've stuck it in there once to get more free up. So this is a little technique that I use. I will find a reflex hammer or a little goniometer or something that I can get it out, and now I've got it here, and if I need to go back, I can just go back to my own little stash, right? So I'm gonna get a little bit here. A little bit goes a long way, and I'm gonna rub it all along this IT band. And all this is a lubricant, right? It's supposed to decrease the friction of my skin against her skin. So I'm just applying a little bit here, and I wanna make sure I have it on my thumb, okay? All right, now, my other thumb, no, I'm on the wrong side. Okay, this thumb. All right, so my coddle hand is gonna be here to hold her leg in the position that I want to have it in, right? I'm gonna turn my ring around so that my pokey part of my diamond is not into her. But what I'm gonna do with my thumb, I'm gonna do the quad first. I'm gonna release quad first. So I've got her here in this position. Her knee is flexed, her knee was flexed a little bit. I've got her slightly adducted, internally rotated. And I'm gonna find the IT band and come to where that quad is inserted into the IT band. And I'm gonna take my thumb and I'm just gonna go down here, and I'm gonna J-hook around the trochanter. Okay, I need a little more prep right there. Okay, I'm gonna use the rest of my hand right here to give me some stability. Okay, so I'm here, and I'm just gonna thumb down and around, and off. Here, down and around, around. Okay. Now, if I want to go the other direction, okay, to do the hamstrings, now I can be here, around this, hook it up, okay. I'm just following that groove where the hamstrings inserted in the IT band. Okay. So, as well as the piriformis to a certain extent. So supine, we're gonna get the hip flexed, adducted, and slightly internally rotated. Similar to the position we just had for the IT band release, paratrochanteric release, but a little bit more adduction, internal rotation for this, okay? So we're gonna stand on the same side of the patient, and get them in that position. You can see Dr. Carter here in this picture. He's got that leg right against his chest. I like to use a barrier. I'll put a pillow between my chest and the patient's leg. And we're gonna put them in position and just let them do a sub-maximal isometric contraction. Okay, lay on your back for me. Okay. So go ahead and stretch this leg out straight for me. And I'm gonna take this leg, right? So flexed, adducted, and internally rotated. So foot's coming out, right? You just relax. You're gonna be relaxed. And I'm gonna get a barrier in here like this. Now, ideally, I would come across here and I would use my go-go gadget arm to get a hold here, okay? I probably am not quite gonna get there. It's tough. So I'm gonna back off from trying to grab here. Actually come toward me a little bit. I still don't think I'm gonna be able to, it's close, all right? But here we are, all right? So I'm gonna get here like so, get myself stable. If I can get a hold of the edge of the plinth, I will. Otherwise, I'll just try to get myself in a position. I may get her a little bit lower, so I feel like I can get over effectively. Now, I am not trying to just put all my body weight in here, okay? I'm here, I'm gauging, I'm just going to where I feel resistance. So flexed, adducted, internally rotated, and where I feel like that's it, like right there, I feel resistance. So this is where I wanna hold her. So I can hold her here, and then I can add an isometric contraction. So I want you to hold your leg right here, don't let me move. So you just hold, and I'm gonna encourage a little bit more adduction, maybe a little bit more internal rotation. Hold it, hold, and relax. As she relaxes, I'm gonna take up any slack, okay? All right, resist me again. Don't let me move you. Hold, and relax, okay? As she relaxes, I take up the slack. Maybe I do a series of 3 of these. Let's do one more, okay? Match my force. Hold, resist me, hold, and relax. Now, I'm under control. I am not laying so hard against her that as she relaxes, I'm losing my balance and falling. I've got to stay under control. Okay, so best practice, bring your patient closer to you. So let me go to the other side. So slide that way for me. Again, I want table down, good body mechanics. So I'm gonna bring her up to hip flexion, adduction, okay, internal rotation to the point that I feel. And if your patient is getting a pinchy sensation in the hip, you may have to back off on how much hip flexion. You may have to alter it a little bit. The idea would be that they're feeling a stretch in the back of their hip. Okay, I want them to feel stretch here, not pinch here. So if you cannot get her into a position where she's feeling stretch back here and all she's feeling is pain or a pinch in the front, you probably need to abort the technique and try something different. Okay? But it's a good stretch. It's a good stretch. So flexion, adduction, internal rotation to where we feel like she's caught. Okay? If I can get around the ground and plinth, I would. Alright, but I'm gonna get here, but I'm still under control. I have control of my body weight. If she moves, I'm not gonna fall. Okay? Now resist me, don't let me move you. Hold, 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 and relax. As she relaxes, I'm taking up the slack. Flexion, adduction, internal rotation. Okay? Match my force again. Hold, don't let me move you. Hold, 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 and relax. Okay, good. I can almost get there now. Alright, one more. Resist me, don't let me move you. Hold, 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 and relax. Good. Okay, then I'm going to ease out of this position. And again, I would recheck whatever it was that made me want to do that in the first place. If it was decreased internal rotation or whatever it was that, whatever hip motion might have tipped me off that I wanted to do that, I would recheck. Alright, any questions about that one? Okay. Next technique, so we're going back a slide to the myofascial manipulation of the hamstring. It says this is an excellent preparatory work for subsequent stretching. So again, if I'm going to be working with the patient and I feel like they've got some adhesions or some myofascial restrictions, a lot of times I will start with these type of techniques before I do any manual stretching with them. So I might get in here, I might warm the tissue up with a hot pack. I might warm the tissue up by having them maybe ride a bike, okay, for a couple minutes or doing some exercise just to heat the tissue up, right? Then I'm going to get in here with my hands and I'm going to work on doing some of these myofascial release techniques, restriction techniques. Somebody told me, I had a professor tell me one time that these myofascial restrictions, like you can think about it like a ketchup bottle, right? A ketchup bottle. You try to pour it out, nothing's coming. What do? Well, right, hit 57, right? And that helps me shake it up, hit the thing, and it breaks up some of those adhesions that have formed between those ketchup molecules, and it'll pour out better. So that's similar to what we're doing when we're doing these myofascial techniques. We're breaking up some of those loose adhesions between those collagen fibers, and we can be a little more effective with our stretching techniques. Okay? So this technique, we're going to get our patient into a 90-90 position. There's a myofascial manipulation, and then there's a splaying component to it. So, tell you what, Mason, go ahead and lift your leg up. I'm going to put this here. I'm going to flip this up here. I know that I have a very nubby and bony clavicle and acromion. Okay, so I like to cushion my patient's leg on here because I just feel like it's not, they're not comfortable because they got a bone jabbing into their leg, they're gonna have a hard time relaxing. So I'm gonna get him up here, he's kind of in a 90-90 position. And now what this allows me to do is it allows me to get in here like so. Come on up here. Tell you what, why don't you see if you can straighten your other leg out for me? I think they may be able to see better. Okay, I've already got a little bit of deep prep on my hand from before, but I'm going to put a little bit on here. Just to, again, decrease the friction of my hand, my skin against his. So he's here, 90-90. I can take my fist like so, and I can just do some stroking. So now I'm going distal to proximal. Now I know those hamstrings are inserting the ischial tuberosity. Okay? I'm going to start superficial. Get that lubricant. Like I may need a little bit more. Okay. I can just go down to where they insert. that's one technique. Now, so that's the myofascial manipulation. That slide where it's saying the MCP joints of the hand is a contact, stroking longitudinally from distal proximal all the way to the tube, right? Then if you see at that bottom part here, it says the hamstring may be splayed by applying pressure medially with the thumbs and separating the hamstrings in a medial lateral direction. Is that bothering you up here? Okay. Alright. So, I'm actually going to wipe my hand a little bit, and I'm going to wipe some of this deep prep off. The splaying actually works a little bit better if you don't have a lot of lubricant. If your patient's sweaty, you may want to wipe their leg off a little bit, okay? And now I can come in here and I can feel the heads of the hamstring, right? The medial and the lateral hamstrings. And up in here, and you can feel it probably better proximally, right? Here's the tendon, distally at the knee. So distally, I can feel that separation of the tendons, and I can work down to where I can feel this groove between those muscle bellies. And I can come in here and I can very gently take my thumbs, come in here between the medial and the lateral heads, and splay. So if you can see my elbows, almost like I'm chicken winged out, bring the thumbs in, and as I come in with my elbows, it's gonna splay those heads of the muscle. Right? Now I'm gonna go in here real gentle. We also have to be careful. There are some neurovascular tissue in here, and we don't wanna begin going in here so deep that we are affecting them. But I can work between the heads, separating the medial and lateral heads of the hamstring, and splaying so that's what that last line is referring to. Okay, medial lateral direction, splaying those muscle heads. Okay, so again, hamstrings. What is muscle action of hamstrings? Extend the hip, flex the knee. So if we were to say, okay, you worked hamstrings, what is a technique, a joint technique you could look at the hip? Anterior glide of what?
The femur and acetabular for extension.
Femur on the acetabular for extension. Good. What if we said at the knee? You decide to address hamstrings.
Talking like tib fib or patella?
Anterior glide of patella, or
Things like anterior glide of the tib fib.
why would you do anterior glide tib fib? You're anterior and posterior. So what do we think? If we're talking hamstring, you said hamstring is a extensor at the hip and a what at the knee? Flexor. Okay. All right. So I guess it depends on what we're trying to do. So if we said if a hamstring is a hip extensor, what would it limit? You gotta think through this. So if it's a hip extensor, what is it gonna restrict? Okay. And with hip flexion, so if what would you want to necessarily look at? Maybe first one I thought is you look at a posterior glide, okay? Unless you have reason to think you got something that leads you down a different path. But maybe first one I thought is it's a hip extensor, so it may be limiting my ability to go into hip flexion. Something else that limits my ability to go into hip flexion is posterior glide. Now at the knee, let's go back to the knee, okay? So I've heard a lot of different things, okay? They may all potentially be right, but you've got to connect the dots. If you can't connect the dots, they're wrong, okay? So let's go back to the knee. So what does the hamstring do at the knee? It's a knee flexor. What does it, and this is how we think through this. It's a hip, it's a knee flexor, so it would limit what? Knee extension. What else at the joint do we need to have full knee extension? Superior glide of patella, and what else? Anterior glide of tib fib. So my first line of thought is I'm probably going to go that direction to check that. Now, could you potentially argue the contrary? Potentially, but you gotta be real solid on it and make us follow you connecting the dots. Okay? Alright. So let's say at the knee, what is a supporting intervention that you could do at the knee? If you chose to do some hamstring, transverse soft tissue manipulation, and you followed that with an anterior glide of the tibia on the femur, what would be a supporting intervention to that potentially? Okay, tell me why. The elongation of the hamstring and strengthening eccentrically. I like it. I can follow that. Okay, that makes sense. Now, could you argue the opposite?
Yes.
Potentially, but you've got to be able to show that you have a firm grasp understanding of why you're doing that. Okay, it's a little harder to connect that. Okay, all right, everybody with me? Okay, so we're gonna do, so just like we did of the quads, we're now gonna do a similar technique for the hamstrings and then the gastroc. Okay, so we're talking hamstring. Now, I can have him scoot down just a touch so his feet hang over. If I feel like he is not, if I may decide, that's good. Maybe even, yeah, that's good right there. All right. Now, I also know Mason has a history of some, sorry, I've got really cold hands.
You're good.
Trauma, okay, so he's got some pretty good scar tissue here. Mason may actually have some hamstring fascial tightness. Interesting to see, okay? But I'm gonna be cautious there, okay? But I'm gonna realize he may actually have some hamstring issues based on his history, okay? All right, I'm gonna do that again with the pillow under here, just to get a slight bend in the hamstrings. This is another technique where I like to try to do it standing first. If I can get what I need standing, I prefer to do that. I feel like I can get more of my body into it a little bit easier. If I feel like I can't get the table high enough, then I might choose to go seated. But I prefer to do this one standing. The sheath around the muscles, it can get tight. You can have a myofascial restriction in any direction. Okay, you could have it feel more restricted going from lateral to medial. It could feel more restricted going medial lateral, or it could feel more restricted going on a diagonal. All right. Rescue. Okay. So I'm going to start with lateral medials. Then I'm going to take again a pillowcase, lack of a towel. I tell you who else I use a pillowcase for. My patients who come in with nice black pants on, and I don't want to get towel fuzz on their pants because I know they're headed back to work. I'll also choose the pillowcase for that patient. A little less towel fuzz. All right, so similar to what we did before, I'm going to stabilize above the knee with one hand, and then I'm going to so I'm going to find the IT band, okay, find the groove. I know that hamstrings are now going to be, okay, toward the ceiling, right? Because we flip the patient over. So it's posterior, but it's toward the ceiling, based on how we have our patient positioned. So I'm going to stabilize the distal part of the hamstring here, and I'm going to get the palm of my hand, base of my hand, okay? I'm going to have to show my hand here, all right? And I'm going to bend. This is probably a little better than the quad because you don't have to lift up quite as far to get it over the femur. Okay? And with all these techniques, though, when we get to that real extreme position of stretch, I'm going to get there, stretch, and I'm going to get out, okay? But, and I've made that comment a few times, get in, get out. But when you get in, get out, you still want to ease into it. Like you don't want there to be slack in the tissue and then you like jam the tissue and out, right? You're still gradually taking up the slack, going to in range and out. Taking up the slack, going to in range and out. But we're not just going like beginning range, in range, like that, okay? Does that make sense? If your patient is really uncomfortable, make sure you're not doing that. Make sure you're still easing into it, but when you get to that restriction, push into it, out, okay? So, again, I'm here, I'm stabilizing distally gently. I'm gonna come up here and I'm gonna just push and bend that muscle. Now, we know there's medial head, lateral head here as well. Again, it looks like this. If I wanted to do medial to lateral, okay, I'm gonna do the other leg. Well, let me come across. I'll just be consistent. So I come to the opposite side, right? Now, I can stabilize here. Now there's not an IT band, but I can still differentiate where the quad and the hamstring are. So I've got hamstring here, stabilize, and I can go. Got a little crepitus there. Okay, does that hurt? Okay. Okay, now again, if I felt like there was more restriction, straight plane, or maybe I go a little bit more diagonal, okay? Maybe I go a little bit more this way. Wherever I feel the restriction, I can work on it, okay? But the technique on the slide is lateral to medial, but But just keep in mind, if you find restriction elsewhere, you can treat that. Okay, is it okay if I roll this up over here? Okay, all right. So, IT band, okay, stabilizing distal, coming up here, bend. Now, this feels tighter to me. Can you tell any difference side to side? This is, yeah, this is a lot tighter. Now, whether that has to do with Mason's history, I don't know. But it's tight going lateral to medial for sure. Now I'm gonna be real easier on this spot right here. Okay, so I'm gonna start a little bit more proximal. I'm gonna ease into that. I'm just curious to see. Okay, that feels a little bit more mobile. I really don't feel much restriction. Here the other direction. Okay, so that is what the transverse manipulation to the hamstring looks like, right? So let's go ahead while he's here and let's do transverse manipulation to the gastroc. So here, again, same thing. I'm gonna slide this over a little bit. I'm gonna make sure I'm gonna do this leg first, just to make sure you don't feel like you're falling off. All right, I'm gonna start lateral to medial. So Achilles tendon. I'm gonna stabilize the Achilles right at that musculotendinous junction. Okay, I'm not trying to do an extreme bend of the Achilles tendon. Man, what are those techniques? Oh, we're not there yet. Foot and ankle. We have some techniques coming for that in the next couple weeks. But for right now, I'm stabilizing right at that musculotendinous junction of the Achilles, and I can come here more to mid muscle belly, okay, or just proximal to that musculotendinous junction. And again, I find this groove, get gastroc soleus, and I can bend it. Okay, I can work my way up. Okay, you see what we're almost getting a Thompson test going? You see his toes point? Okay. Now, I also recognize that there are some other muscle bellies, right? We got tibialis posterior here, we got some of the perineals here. So we may get a little bending of those as well. But this is primarily a gastroc technique. Okay, again, I think these are a little more tolerable than the quad. The quad seems to be the worst. So stabilizing here. What does this side feel like to you, Mason, compared to the other side? Any difference or not?
I don't feel much. Maybe this one's more mobile.
Yeah, I don't feel a big difference. Just curious if it translated on down. Okay, so then also, again, same thing here. If I wanted to treat the medial to lateral, I could also get here stabilized, and I can move medial to lateral. Okay. I'm going to get my patient, we're talking about hip flexors, iliacus and psoas. We're going to do those techniques. So, hip flexor, right? Now, so hip flexor, we know we're going to do iliacus first. I'm going to slack them, put a little bit of slack in there. With the iliacus, you can probably get away with just a pillow under the knee. With the psoas, I really want them up, okay? Ideally, you get them closer to 90-90, but you're going to put some slack in the tissue. All right, actually, do you mind if I bring this down just a touch, just to get your ASIS? Okay, I'm just gonna go right here. All right, my hands are cold. All right, so I'm gonna come right here. We're probably okay. I'm gonna go through, I wanna, if I'm doing this through clothing, I wanna make sure I'm not pushing through a seam. There's a lot of seams right at the waistline. So you don't wanna push through a seam, okay? You can use your judgment with your patient, but here's where we're gonna be. Okay, here's the ASIS, and we can see this skeleton is painted right here where iliacus inserts, right? So if I'm going to go for this iliacus, I'm going to come in here with my fingers, okay, right in ASIS, curl right around, and I'm going to find that. I can do inhibitive pressure. Now, if I were going to do longitudinal, parallel to the muscle fiber, which direction is that going to be?
Superior.
superior inferior, right? Or cephalic caudal. So that's the orientation of the muscle fibers. So that's where I'm gonna start probably. And then if I'm gonna go transverse and perpendicular, it would look more like this, okay? So I'm gonna start by just hooking around the ASIS, and you'll feel, as you come around here, all right? Okay, muscle right here. So I can feel some tension in there. I'm feeling for the tone, also feeling for any top bands. So I'm gonna do some longitudinal strokes, some parallel to the muscle fibers, okay? See here, ASIS, may I bring this down just a touch? Okay, ASIS coming right here, hooking in. I can feel the muscle like I'm hooking down like this. There's the muscle. Longitudinal, okay? If they tolerate that okay, eventually we could go to a transverse. All right, now I'm gonna come around, other side, same thing. I'm gonna make sure I'm not pushing through seam, and I'm gonna compare. So I'm coming here, hooking, ASIS. And I feel the tone, the tension here. I can stroke longitudinal, transverse. How's that feel to you, this side compared to the other side?
I think it feels about the same.
Yeah, not a big difference. Okay. So that is the iliacus release. Right. So iliacus joins with what other muscle to form the iliopsoas? Psoas, right? Okay. So here's the iliacus portion. We know that the psoas portion is here. Yeah, roll this up. Okay. So we're gonna roll this up where we can expose and get here, and I'm gonna bring this down just a touch below it so that we can see our landmarks that we're going to for the psoas. Okay, so psoas also inserts, in addition to with iliacus here at the front of the pelvis, where else does it insert?
On the
Lower lumbar, right? So the transverse processes, actually the body, okay, kind of the anterolateral surface of the body of the vertebrae, and even some will say even into the disc, okay? So if the hip flexor is tight, not only does it flex the hip and limit what motion at the hip? Extension. What does it do in this lower lumbar?
Anterior pelvic tilt.
An anterior pelvic tilt, okay? Or an increased lumbar lordosis, right? So this may pull me into some lumbar extension. So if it is restricted, it may limit my ability to go into lower lumbar flexion, okay? Or posterior pelvic tilt. So keep that in mind as well, all right? So if we're gonna find the psoas, we're gonna find umbilicus, belly button, and we're gonna find the ASIS, and we need to know where the rectus abdominis is, okay? So rectus abdominis are six-pack muscles. So I can kind of see on Kendall, I can see that delineation here. This is the lateral border of her rectus abdominis. So I know that psoas is gonna be a little bit inferior to the umbilicus, and I'm gonna come out here to the rectus, and I'm gonna come at a I'm gonna put the table down just a touch. 45 to 60 degree angle, just lateral to the rectus abdominis, and I'm gonna come down here like so, and I'm gonna just gradually. This is a sensitive area, okay? I'm gonna gradually sink down. I'm kind of following her breathing. I'm letting her breathe normal. As she inhales and as she exhales, I'm going down a little further, and I'm sinking down. There's still more to sink. Until I feel firm, like right, ooh, there. That's probably it, you okay? It's not a real pleasant place to be pushed. Now I need to confirm that I'm on the right place. So this is what I'm gonna do. I'm gonna have Kendall unweight her left leg, like she was gonna start to lift her leg and go into hip flexion, but I don't want, yep, that's it. So that was enough right there. When she went to unweight it, I could feel her hip flexor contract in my finger. So I know I'm on the right spot. So I'm just gonna hang out here, okay? See how she tolerates, feel the resting tone. I can do inhibitive pressure. Again, if she's okay with this, and I want to investigate a little bit more of that muscle, I'm going to start longitudinal. Okay, so parallel to the fibers. So for the psoas, again, that's more of a superior to inferior stroke. Okay, there's kind of a top band right there. Is that sore? Does that radiate anywhere? Or is it just sore where I'm at?
Just where you're at.
Okay, Okay, so I feel a little taut band right there. So I might hang out here and just let her breathe. Now, I'm on her left side. Let's talk anatomy a little bit. I feel this releasing a little bit. It's still the taco. So anatomy, so the abdominal aorta comes down in this realm of the world, okay, and it bifurcates in most people just above the umbilicus, okay, but there are people who have, and here we go, it's releasing, an aneurysm, right, an AAA, AAA, abdominal aortic aneurysm, and so if you get down in this area and you're palpating and you're feeling a pretty strong pulse, I'm going to think back because that aorta, as it descends, it sits just to the left of the spine, okay, and it comes down here and then it bifurcates into your iliac arteries. But if you're going in here and you're feeling a really bounding pulse, I have to start to think, I may come back up here and then I'm going to palpate and see if I can find, I can feel her pulsing here, right? I'm going to make sure that I don't feel like there's a, whoa, yeah, like I feel pulse, oh, pulse out here, pulse. Just make sure we're not feeling a wide pulse, okay? Your patient doesn't have, like their symptoms just don't make sense. You're having a hard time finding something that's making it better, making it worse. Keep in mind there can be other causes, and that can be a significant one of low back pain, okay? So just remember that. On the right side anatomy, what else is on this right side in this area that can cause pain? Appendix, right? You guys remember McBurney's point? Did you learn that? It's in a real similar area. It's not exactly the same spot, okay? But McBurney's, right? Umbilicus, ASIS, you're about 2/3 of the way over here, you're gonna be near where the appendix is. So if you get down there and they're like, oh, yeah. And then you try to ice, you do your little, that's why we use our confirmation technique to identify. Because if it's not the muscle and it's real tender, I'm also kind of thinking in my mind, make note of that. Or do they have any other symptoms that would be suggestive of appendicitis? If so, I need to call the doctor, okay? That's probably not what brought them in for you, but it could be. Or it may be something that develops as you're treating them, okay? You might be treating them for hip and knee pain, and all of a sudden they tell you, man, I just hurt over here today, right? And you're in here and you're checking their hip flexor and it's tight, and you go in there and you're like, and then you light them up, it might be worth to call the doctor, okay? Especially if we got fever or any other symptoms that would be suggested. But again, review, umbilicus, slightly inferior, rectus abdominis, I'm coming just lateral. We don't want to be compressing that. We want to go just lateral that, 45 to 60 degrees, okay? I'm going to sink down. I'm going to follow her breathing, her exhalation. You can see I've almost buried my finger here in Kendall's belly. And she's not that deep, okay? All right, I want you to start to unweight. All right there, relax. Now, I don't feel, it's probably not comfortable, but I don't feel the top band on this side that I felt on the other side. Okay. So I'll just hang out as long as I need to. Alright, so then what might we follow that up with? Hip flexor. Let's talk hip joint. What might we follow that up with? Okay. Maybe some marches. Okay. This is a muscle that I wish I'd have been paying a lot more attention to right out of the gate. I pay more attention to it all the time. Okay. The more I practice, the more I pay attention to the diaphragm. It's an important one. So when we talk about just this cavity, and I'm going to relate this to spine a little bit, but you've got 4 muscle groups that are really working together to manage pressure in this area, right? You've got your lower back muscles here, you've got your abdominal muscles here, you've got your diaphragm, superior side, and you've got your pelvic floor, this side. So if we have weakness or poor coordination of any of those muscle groups, and when we do anything forceful, whether that's cough, sneeze, lift, okay, jump and get that impact. If we don't have good coordinated muscle contraction and function of all four of those groups, then things get pushed wherever the weakness is. So that can relate to you. That's where how maybe you have a hernia develop. You got some abdominal weakness, maybe somebody has a diastasis recti, right? We may see some herniation there. Somebody has some weak or poorly coordinated pelvic floor, we may see some prolapse, some organ prolapse, okay? So diaphragm is very important. When we're doing exercises, breathing is really, really important, okay? But we're gonna look at a diaphragm release. So this technique, we're gonna do it seated like Dr. Carter is demonstrating in the picture. So this, it says, many patients with a chronically slumped posture need to have this area released in order to free them up to stand to elongated position. So you can probably even feel this in yourself. If you slouch down, you can see how maybe that's going to bring the ribs and the spine and this area is closer together, and that diaphragm may get to a short and tight position. Okay, it's harder to breathe here, right? Than it is here. I can take a much better breath here than I can slumped. So I'm going to have her go into a slumped posture and position because this is going to shorten that muscle. It's going to put slack in it, okay? And I'm going to reach around and I'm going to find the bottom of her rib cage. My hands are cold. I'm sorry, okay? And I'm going to come right in here to the front of her rib cage, okay? Now, I can get my fingers in here and just hold some inhibitive pressure. It's like I'm coming up under it like this. Trying to curl up under here like this. I can hold pressure and I can work and do some medial and lateral stroking. Okay? So again, we're starting slumped. So go ahead and slump down. Coming right up under here. Inhibitive pressure. There we go. Do some medial and lateral. If she's able to tolerate that, I can have her sit up in a little more erect position. As she comes up, I can get them a little different. Come down here and work on that. So we start slumped, we start slacked, and we do some release, moving into a more upright position. Now, let's connect these dots, sorry about the fingernails, connect the dots with the spine as well and the hips, right? So if this is tight and we're in a slumped position, we are trying to improve upright posture. Let's say we wanted to follow this. We said, what's a joint mode that you could check at the hip? What do you think? So you think extension? You want to improve in extension, right? Because you're stuck in flexion. I can buy that. So what mode would you look at? Anterior. Good. What if I said, let's just talk spine. I know we haven't really done this, but let's talk spine. What about thoracic spine? What do we want to improve? Extension, right? So we'll get to that, but you would do a mode that would probably look at something you can do to improve extension, right? And if there is nothing else that hopefully you remember this, I think we talked about this in intro ortho. If I want to have full shoulder flexion, what do I need to have in my thoracic spine? Extension, okay? Know that, all right? Know that. So extension, and even at the shoulder now, what could I work to improve? Okay, scapular retraction. How about glenohumeral joint? Okay. How about flexion? Okay. So we can do something to improve flexion. Okay. Okay. You might could argue extension too, but something that's getting you out of this position, right? Or we're internally rotated. This is an internally rotated position. You could argue something that's going to improve external rotation. Okay. So connect all that. All right. So that's diaphragm. Go ahead and lay down. So we might find that you can do better if your patient's not as tolerant in that position. We could also get to the diaphragm here, which I'm probably more inclined to do. I can get her here. I can get her legs bent. You can probably see this a lot better too, right? But I can come here at the diaphragm. Again, this is another spot where I might pick up and on that aorta being a little bit prominent. But I can get under her ribs a little easier right here. So I can just feel, and I actually feel Kendall maybe a little tighter on her left side of her diaphragm. So I can follow breathing just as she exhales. I follow in a little deeper. work toward doing some medial, lateral, longitudinal strokes. Okay, so that's the diaphragm. Last technique is a superficial fascial elongation of the caudal trunk fascia. Okay, ideally you do this skin on skin as well. We're not at this moment, but may I roll this down just a touch? So if I'm going to try to stretch this is similar to what we did at the shoulder. When we brought the shoulder up, we got the hand here, and we tried to elongate the anterior fascia of this chest and shoulder complex. It's a very similar technique at the anterior part of the hip complex. I'm going to go ahead and take this out, and I'm going to get you into more of an extended position because we're trying to encourage motion or stretching of the fascia. So bringing you into extension is going to help encourage that motion. Okay? So with this technique, I'm going to take one hand here, focus up a little bit more. I'm going to get as broad of a contact with my hand as I can. And I'm not compressing. This is not compressing. This is just enough compression to be able to get a hold of the skin and fascia and move it. And then I'm going to take my other hand here at the top of the thigh, proximal thigh. Okay, again, ideally skin on skin, but I'm going to try to stretch those 2 points away from each other. Again, enough compression just to move the skin. Do you see how if I get right here and I move this, look at her belly. Can you see how the skin on her belly, and you can see that myofascia moving on her belly, even though I'm not touching her belly? Right? Same thing here. If I move her here, do you see how her pants start to tighten up, lower? So obviously there's fascial connection. So here, broad contact, okay? And just stretching. Now, I can go more across, I can go more straight vertical, I might come more this way, depending on where I feel the most restriction. And I'm just gonna get here and hold. I need enough friction that I don't totally slide off, but I may be inclined to use just a little bit of deep prep, okay, just a little bit of lubricant, so that I get a little bit of slide. I want a little bit of slide here with that, okay? On the other side, looks like this. I'm in a lunged position, okay? Nice firm, but soft. I don't want to be nubby, and I don't want her to sense tension in my hand. If she feels the tension in the muscles of my hand, she's not going to relax as well. So I want a soft hand, but enough that I can get a hold of the fascia. And then here, like so, forearm, and I'm just separating the two. For your practical, try as best you can to come to where your partner can get skin on skin at shoulder, belly, hip, shorts that you can roll up. Do your best to do that.